This staff training video is provided courtesy of the Association of Certified Dermatology Techs. To learn more about our online 15-hour certification course for dermatology medical assistants and clinical support staff, please visit dermatologytech.org. So the big question is, are you ready for ICD-10? If the answer is no, then you're not alone. We're going to help you better understand what to expect with these upcoming changes, but before we get started, we of course need a disclaimer. The purpose of this video is to serve as an introduction to ICD-10. Although we're going to cover quite a bit, those who play a significant role in the coding process will certainly need additional training, both in preparation for the implementation of ICD-10, as well as ongoing training as the ICD-10 code set evolves and is updated. Let's first take a step back and consider that some watching this may be new to the field and might be completely unfamiliar with the coding process. So for those of you who are familiar with the basics, bear with us for just a second. Ultimately, coding is simply the language that we use to provide a summary of the office visit charges to a patient's insurance company. There are three types of codes which make up these charges. They include the Evaluation and Management, or E&M codes, the Procedure codes, and the ICD codes. The Evaluation and Management codes indicate the complexity of the office visit, and the Procedure codes tell insurance which procedures were performed. The good news is that technically speaking, both the E&M codes and the procedure codes are part of the larger CPT code set, and their use will not change with the implementation of ICD-10. New patients whose visits are normally, let's say, a 99202 or 99203 will still be coded as a 99202 or 99203. Freezing a wart will still be charged as a 17,110, and so on. Instead, it's the ICD codes which indicate the diagnosis or diagnoses made, or at least addressed, during a given office visit. It's only the ICD codes that we need to be concerned with when the change occurs. Under the current ICD-9 code set, typical examples would include 706.1 for acne, 691.8 for atopic dermatitis, and 702.0 for an actinic keratosis. Those of you who have been working in dermatology for a while now probably have these codes memorized. ICD stands for International Classification of Diseases. In the United States, we're currently using version 9, also known as ICD-9-CM, and have been doing so for years. As the word international implies, the ICD codes essentially serve as a universal language so that diagnoses can be easily understood throughout the world, without language or cultural barriers getting in the way and causing confusion. In fact, the World Health Organization is the party responsible for the creation of the ICD codes. The latest version, ICD-10, has actually been in use by most other countries since the 1990s, and it's really just now that the United States has finally committed to join the rest of the world in its use. Specifically, there are two versions of ICD-10 that will be implemented here. ICD-10-CM deals with outpatient clinical diagnosis codes, which is what affects those of us working in dermatology. The CM stands for Clinical Modification, and it's a version of ICD-10 which has been modified by the National Center for Health Statistics for use in the United States. It's ICD-10-CM that we need to worry about. You should also know that there is another version called ICD-10-PCS, which will be implemented as well. However, it is only for inpatient procedure codes, such as in hospitals, so with very little exception, the average dermatology practice does not need to worry about ICD-10-PCS. As the time draws closer, you will likely hear the date of October 1st, 2014 repeatedly. The reason is because the U.S. Department of Health and Human Services, or HHS, has issued the final rule mandating that everyone covered by the Health Insurance Portability and Accountability Act, or HIPAA, must implement ICD-10 for medical coding effective October 1st, 2014. It will be interesting to say the least, because claims submitted on September 30th will still use ICD-9, and literally the next day forward, from October 1st on, ICD-10 will be mandatory. And therein lies much of the anxiety surrounding its implementation. There will not be a transition period in which we can optionally use ICD-9 after that date. If we get frustrated or forget and mistakenly code a visit using an ICD-9 code after October 1st, 2014, the claim will not get processed and we won't get paid. Understanding the benefits of ICD-10 may help to ease the frustration that many of us are bound to feel during the transition. Although there are multiple reasons behind the switch, consider this. Epidemiologists study the patterns and causes of health issues within the population as a whole. By monitoring disease patterns, they can bring attention to diseases and conditions that deserve increased consideration by researchers, physicians, and health insurance companies, just to name a few. For example, the incidence of melanoma has been increasing a lot in recent decades. Because epidemiologists have noticed this pattern, there has been an increase in research regarding the causes and treatments of melanoma. As you can imagine, epidemiologists and others, such as in the insurance industry, would like to see detailed statistics on every disease and injury, and analyzing the ICD codes assigned by physicians throughout the country is the easiest and most efficient way of doing that. But epidemiologists don't just want data. They want quality, specific data, and that's where the problem lies with ICD-9. Too many unique variations of diseases, conditions, or injuries share the same ICD-9 code. For example, let's say that researchers are studying a group of 1 million people in order to better understand the impact of psoriasis. With ICD-9, that's as specific as it gets. That is, that 30,000 people have been diagnosed with psoriasis because all 30,000 patient visits shared the exact same code, that being 696.1. The ICD-9 codes can't differentiate one type of psoriasis from another. But with ICD-10, those same 30,000 psoriasis diagnoses are broken down more specifically. ICD-10 might show that 23,000 people were diagnosed with typical psoriasis vulgaris, or L40.0, 5,000 people were diagnosed with guttate psoriasis, which is L40.4, and the remaining 2,000 patients were diagnosed with pustular psoriasis on the hands and feet, which is L40.3. Now, if you were a researcher trying to better understand the incidence of psoriasis and how it affects different groups within the population, which data would you prefer? That provided by ICD-9 or that given by ICD-10? Of course, the answer would be the more specific breakdown provided by ICD-10. ICD-10 also greatly reduces what often seems to be completely illogical code sharing between totally unrelated diagnoses. For example, with ICD-9, even though melasma and solar lentigines are two very different diagnoses, they both share the same code of 709.09. In fact, there are quite a few such shared codes in ICD-9. With ICD-10, most unique conditions or lesions will have their own code. Using those same diagnoses as an example, melasma has its own code of L81.1, and solar lentigines will have their own code of L81.4. And therein lies both the beauty and the frustration of ICD-10. It's great for epidemiologists, insurance companies, and researchers, and there are even times when the added specificity will make the assignment of a diagnosis more logical for those of us on the clinical side. But with all of this added specificity comes a lot more codes. And guess who's going to be responsible for choosing from amongst those codes? Most of the time, the answer will be us. So let's go over some of the key features that distinguish ICD-10 from ICD-9. The first we've already mentioned, and that is that ICD-10 will provide much greater detail than ICD-9. The arguably annoying buzzword that you're likely to hear a lot over the next year is granularity. It's a term that means the state or quality of being composed of many individual pieces or elements. So again, using psoriasis as an example, consider how it's coded in ICD-9. We only have the one code, 696.1, and that's as specific as it gets. By contrast, in ICD-10, psoriasis is in the category of L40, which is then granulated or broken down into numerous individual pieces or elements, providing us with the more specific diagnoses that we see here. In order to reflect this greater degree of detail, there's no getting around the fact that many codes will be longer. In fact, depending on the diagnosis, we're talking up to 6 or rarely even 7 characters. Fortunately though, in dermatology, the vast majority of codes are going to be in the 4 to 6 character range, with the longest typically being the neoplasm codes. For example, consider the ICD-10 code for squamous cell carcinoma of the right eyelid, which is C44.122. At 6 characters long, it's longer than anything we're used to seeing in ICD-9. And one of the reasons that the neoplasm codes are so long is because laterality, that is, whether the lesion or condition affects the right or left side, will be indicated in certain ICD-10 codes. Let's look again at the codes for an SCC on the eyelid. The sixth character in the code for an SCC on an unspecified eyelid is 1, while that of an SCC on the right eyelid is 2, and one on the left eyelid is 9. This is actually a common pattern seen throughout the ICD-10 neoplasm codes. Another unique feature of ICD-10 is that certain diagnoses will need to be described using more than one code. Take the category of abscesses, furuncles, and carbuncles as an example. When coding for an abscess, we're asked to also provide a code for the causative bacteria. We'll talk about this use additional code note in more detail in just a few minutes. On the contrary, we'll also find that certain codes in ICD-10 will actually represent more than one diagnosis. These are called combination codes. They aren't very common, especially when it comes to dermatology-related codes. When they are seen, it's usually with respect to complication-prone systemic conditions such as diabetes. For example, here we see that code E08.62 includes the description for both diabetes as well as skin complications resulting from the diabetes. And another feature that ICD-10 brings us is that diagnoses can be marked as resulting from a preceding infection, injury, or illness. These are known as the late effect or sequela codes. For example, let's say a patient comes in for their first visit and is diagnosed with scabies. The code for active scabies infection is B86, one of the rare 3-character codes that doesn't break down into a more specific code. So the patient is treated and now returns for follow-up 2 weeks later. At this point, they still have some residual pruritus, but they're no longer infected. Because the previously used B86 code represents an active scabies infection, we should avoid using it. Instead, we would first code for pruritus since that's the patient's current symptom, but by adding the late effect code of B94.8, we can indicate that the pruritus is the result of the preceding scabies infection. Of course, the first thing that some of you might be wondering is why are we using 2 codes? Well, this is one of those situations we discussed a moment ago, where 2 codes will be needed to describe the same condition or injury. We'll go over this new requirement in greater detail in just a few minutes. And the last of the features that we're going to highlight is that of greatly expanded coding that describes what we're going to call situations and circumstances. These would include times when a person who may not be sick comes in for a specific reason, or when circumstances influence a person's health status, but those circumstances aren't an actual illness or injury. This code expansion won't affect dermatology nearly as much as a few other specialties, but some examples of these types of codes would include describing a visit for skin cancer screening, post-op nurse visits, or even when someone has a personal history of melanoma. We actually have those types of codes in ICD-9 already, but some examples of a few interesting new ones that we might occasionally use would include something as simple as checking a patient's blood pressure. Let's say a patient who has a history of high blood pressure is asked to come in the day prior to surgery for a nurse visit to get their blood pressure checked. If no other code applies, then this one might come in handy. And there will now be a code to describe an encounter for allergy testing, which presumably might be used if your office does patch or even RAST testing. Another situation that occurs every now and then is when a child is diagnosed with scabies or even head lice, so their parents insist on bringing in their siblings for a screening. Assuming the siblings aren't infected, then a code like this one would be the most appropriate. Of course, only time will tell how practical, or should we say reimbursable, codes in this category prove to be. All ICD-10 codes are officially found in 2 different documents provided to us by the National Center for Health Statistics. We say officially because there will, of course, be a number of aftermarket documents and software programs, such as those provided by the AAPC, Inga-Elzy, EMR vendors, etc., that in all honesty should make things a lot more user-friendly. But that said, the official sources are the ICD-10-CM Index to Diseases and Injuries and the ICD-10-CM Tabular List of Diseases and Injuries. The index is just as it sounds. It's just like any other alphabetical index in the back of a book, and provides a way of quickly referencing the various code categories. However, the full listing of codes and instructions can only be found in the tabular list, and we are advised to avoid using the index for final code selection. Instead, we are asked to use the index to tell us where we should look within the tabular list. The tabular list contains the full comprehensive listing of codes and includes all special notations and instructions. It's broken into various chapters, most often based on general body system. For example, Chapter 12 is where we'll find diseases of the skin and subcutaneous tissue. You'll also notice when you see the tabular list that all codes within a given chapter will begin with the same letter. For example, all of the Chapter 12 skin disease diagnoses start with the letter L. If you don't already have a copy, you can click either link to download the latest PDF versions. As we get into the discussion about the instructions found within the index and tabular lists, there's one point that most of us will ultimately agree on. And that is that once ICD-10 is implemented, we will feel very fortunate that we work in dermatology. The ICD-10 coding rules, which you will sometimes hear referred to as conventions, will affect everyone to some degree. In all honesty, though, those of us in dermatology will have it relatively easy. A number of other specialties, especially those that regularly deal with orthopedics, injuries, and chronic illness, will have it much harder. But regardless of our specialty, when it comes to following these rules or conventions, it's all about following the instructions. And ICD-10 involves a lot of instructions, so let's go over the most common. The first of these are the Includes Notes. The Includes Notes generally provide clarification. A common scenario is when synonyms are provided for a given diagnosis. For example, when we're looking up the various forms of alopecia, this Includes Note clarifies for us that the diagnosis L64 for androgenic alopecia includes the lay term male pattern baldness. It's the Excludes Notes that can get somewhat tricky. There are two types, and there's really nothing intuitive about how they're named. The so-called Excludes 1 notes are there to tell us that we cannot code the listed diagnoses at the same time. For example, let's say a patient is diagnosed with acquired epidermolysis bullosa, or EB. Well, patients either have acquired EB or they have congenital EB, but not both. So under acquired epidermolysis bullosa, the Excludes 1 note essentially reminds us that we cannot use the congenital EB diagnosis at the same time. In other words, pick one or the other. In this scenario, it makes sense, but just know that there may be times when the logic isn't so clear as to why certain diagnoses are on a particular Excludes 1 list. On the other hand, the so-called Excludes 2 notes are there to clarify that the listed diagnoses aren't part of the represented code, and if applicable, can be made at the same time. For example, for various acne diagnoses listed under the category L70, this Excludes 2 note is here to remind us that the diagnosis of an acne keloid is not included in any of the L70 categories, and if needed, we can list the code for acne keloid as well. In other words, it essentially says, if applicable, you can pick both. The C notes are self-explanatory and are something that anyone who has used an index in the back of a book would be familiar with. They simply point you in the right direction. Let's say you're trying to select the correct code for a patient who's got a poison ivy rash. You know it's a form of dermatitis and that it's allergic, so that's where you look first in the index. Here, the C note points you in the right direction, essentially telling you to first look under dermatitis, which you're already there, but then look under contact, and then under allergic, and that's where you'll likely find the code you're looking for. The C also notes are a little different from the C notes. A C also note is most often used to provide alternative locations in the index where the most appropriate code might be found. The keyword here is might. They're simply presenting you an alternative that you might want to consider, but it doesn't necessarily mean that you'll find the best code there. For example, let's say that the doctor you work with referred to a given lesion as a papilloma. So of course, that's where you look first in the index. The ICD-10 authors realize that the term papilloma may be used in a variety of diagnoses, some of which are more popularly referred to by another name. Therefore, the first thing you see when looking up the various types of papillomas is this See Also note, directing you to consider looking under neoplasms, benign, by sight, if you don't find what you're looking for under papillomas. The Use Additional Code notes mean just as they sound, and we saw a preview of this a few minutes ago when discussing some of the key features of ICD-10. These notes instruct us that another code should also be used. It's worth pointing out that unless they're presented as an option, with wording such as if applicable, then it will be required that we use the additional code. Luckily, we won't see these too often in dermatology. If anything, we're probably going to see the use additional code notes most frequently when dealing with infections. So let's say a patient has impetigo. At the top of the category, we're told to use an additional code to identify the infectious agent, and the various infectious agent codes range from B95 through B97. The code first notes are like the use additional code notes, but with an added requirement. Code first notes instruct us that we must not only use an additional code, but also that the additional code should be listed first on the superbill. The code first notes are used most often to describe variations of a larger, often systemic disease. We won't see them too frequently in dermatology, but an example would be with the L14 category of bullous disorders and diseases classified elsewhere. Let's say a patient has a bullous subtype of systemic lupus erythematosus, or SLE, in which the lupus is causing blisters throughout the skin. If we just use the diagnosis associated with SLE, that doesn't quite adequately describe the patient's situation. Instead, what we could do is first, as we're instructed in this note, use the code for SLE, and then add the L14 code to indicate that this patient is suffering from bullous changes as a result of their systemic lupus. If there's one of the new ICD-10 instructions that will make us thankful that we work in dermatology, the requirement to add the appropriate seventh character to certain codes will be it. For certain visits, a seventh character code is required. Let's repeat that. Required to provide added details about a given visit. Codes which require a seventh character are going to be very rare for us in dermatology, but they're extremely common in the codes which describe injuries and accidents. Depending on the practice setting, occasionally in dermatology we will repair accidental lacerations, so we'll use that as an example. The code we're looking for is here, S01.01, laceration of the scalp without a foreign body. Well, at the top of this category, we see these instructions that say the appropriate seventh character is to be added to each code from category S01, and then describes how A will be used if this is the initial encounter, D will be used if this is a follow-up related to the laceration, and S will be used if this is a sequela of the laceration. That is, the patient is being seen for something else besides the laceration, but which was caused by the laceration. For example, they're coming in a few weeks later asking for pain medicine because of the associated pain, but the laceration itself has already been treated and is no longer an issue. To keep it simple, let's say that this is the initial visit. Well, we know that the base code is S01.01, but if we add the A to the end, that only makes 6 characters, and they're asking us to add a 7th character. That's where the placeholder X comes in. Anytime we're asked to extend out to 7 characters, but simply adding the required additional character leaves us short of 7 characters, we're supposed to use the letter X to help make up the difference. So here, for example, we would simply add the letter X, and then add the A as the 7th character, which indicates that this is the initial encounter. Can you imagine doing the billing for emergency rooms once these changes go into effect? We'll be thankful that we won't be dealing with the 7th character codes very often in dermatology, but when we do, we at least need to know how to handle them. There are a number of punctuation marks used within the ICD-10 index and tabular list as well. Their significance is usually easy to understand, especially when seen in their context. A few of the most common examples include parentheses, which most often just provide additional terms used to describe a given diagnosis. For example, in the index next to the term dermatitis, we see eczematous in parentheses. This is because some people will refer to dermatitis as eczematous dermatitis, and the parentheses are there to simply confirm that the term eczematous dermatitis would be coded as L30.9. Brackets are most often used to provide synonyms or explanatory phrases. For example, the brackets here provide us with the synonym for benign familial pemphigus, which of course is Hailey-Hailey disease. Hyphens or dashes are used in a few different contexts in the index and tabular list, but their most significant meaning when referencing ICD-10 codes occurs with what is called the point dash. The point dash is used to represent the more specific codes that exist following the decimal point of the listed category. For example, in this excludes to list, we see that it lists viral warts and, in parentheses, says B07 point dash. This essentially means that the excludes to rule here would apply to the entire B07 category of viral warts, including all subtypes such as B07.0, B07.8, and so on. And finally, there are some abbreviations you should be familiar with as well. The two most important abbreviations are NEC and NOS. They do sound fairly similar, but their significance is actually quite different. NEC means not elsewhere classified. It should be used to describe the rare circumstances where you have a specific diagnosis, but that diagnosis just isn't found anywhere in the tabular listing. For example, consider a patient who is diagnosed with a rare deep tissue fungal infection. We do occasionally see this in dermatology. The lab has confirmed the type of fungus, but it's so rare that it's not even listed anywhere within the tabular listing of infections. So after searching for that particular infection, we can't find it, but we see here that B48.8 includes infections of tissue and organs by saprophytic fungi, NEC, or not elsewhere classified. In the end, this is the best code for this situation. NOS, on the other hand, means not otherwise specified. It all too often means that we aren't able to provide further specificity for a given diagnosis. And because the whole point of switching to ICD-10 is to provide more specific diagnostic data, you can imagine that not providing the requested specificity can be a recipe for a rejected claim. For example, consider the diagnosis of pressure ulcer. This is one of the categories in which ICD-10 authors have gone to great lengths to list all of the various stages of the diagnosis. So here we have all of these options, with unstageable meaning that you simply can't stage it because it's bandaged or the overlying eschar is too thick. In other words, circumstances beyond your control. But that's pretty rare, and we're otherwise given the option to classify the ulcer as stage 1, 2, 3, or 4. So with all of these options available, how happy do you think Medicare or even a private insurer will be if we choose this code here, which essentially means, yeah, it's a pressure ulcer, but we didn't stage it, or our documentation is so poor that our coder can't provide you with the stage. The truth is that sometimes we simply won't have a choice but to use one of these not otherwise specified codes. But just know that, when possible, we should try to avoid them when more specific codes are available. As you've probably figured out by now, ICD-10 coding will be associated with certain requirements that must be followed, or the claim will not get processed. If claims don't get processed, cash flow comes to a halt, and without the cash flow, none of us get paid. When it comes to what will keep dermatologists and their practice managers up at night, this is it. Everyone on staff within a given dermatology practice will need to be mindful of these requirements so that everything doesn't grind to a halt when October 1st, 2014 arrives. So if you remember nothing else about ICD-10, at least remember this. We must code to the highest degree of available specificity. Remember, the added specificity that ICD-10 offers is the very reason behind the change in the first place. Let's use seborrheic dermatitis as an example, as it's an incredibly common diagnosis in dermatology offices throughout the country. If we were to quickly scan through the tabular listing and see here where it clearly says seborrheic dermatitis and think that we're done, we'd be wrong. According to the new guidelines, the only time we're allowed to leave the final code selection at the 3-character category code is if no subdivisions exist. If they do, then we must choose the final code from among those more specific diagnoses. And just as the codes need to be more specific, the visit documentation must support the added specificity of the codes we're using. This point cannot be overemphasized. With the widespread use of electronic medical records, physicians and other providers are relying increasingly on their staff to assist with documentation. If a given ICD code depends on whether a lesion was on the right or left side, the notes must clearly indicate that. If, as mentioned a moment ago, a patient has an infection and a specific bacteria has been identified, then the note must state that. Most of you already know whether or not your office is in the habit of producing quality, thorough documentation. Just know that if you work in an office where the documentation is sparse, incomplete, or sloppy, then that's going to have significant ramifications on how efficiently the appropriate codes can be assigned to each visit once this all goes into effect. And finally, all instructions provided to us within the tabular list must be followed. Examples include the Excludes 1 notes, Excludes 2, Code First, Use Additional Code, etc. We've already touched on these, but the point here is that first, most of the instructions are not found in the index, which is why we should always refer to the tabular list for the final code selection. But also, the instructions they provide are not put there as suggestions. They are a requirement that must be followed for selecting the correct code. Taking a cynical view, remember this: incorrect code selection, or sometimes even incorrect placement of those codes on the claim, will give private insurance, as well as Medicare, Medicaid, etc., a valid excuse to deny payment. Again, it's a bit cynical, but it stands to reason that the more excuses that there are to deny payment, the more payments we're going to see get denied. The best approach for us will be to follow the instructions provided, select the correct code, and if applicable, place it in the correct order on the claim, and not give them an excuse to deny a claim in the first place. And now it's time for you to check it out for yourself. Once again, here are the links to download the index and the tabular list. A tip in case you don't already know: after you click, download, and open either PDF, it's easy to get overwhelmed with just how much information is in each of them. Just know that anywhere that you see blue-colored text, that's somewhere that you can click, and it will take you to that point in the document. If you know exactly what you're looking for, a better solution might be to search the document. To search a PDF like these, you'll need to press the Ctrl and F buttons at the same time, and you'll see the search box pop up in the upper right-hand corner. While this can enable you to quickly find a given diagnosis, you may discover just how finicky the code sets are when it comes to terminology. If you don't refer to a diagnosis exactly as it's written, then your search may come up empty. Otherwise, some additional resources that can help you to better understand ICD-10 will include arguably the driest and most boring option, that being the Center for Medicare and Medicaid Services, or CMS. As with most government websites, it's not the most engaging, but it is free. The American Academy of Dermatology also serves as a good resource for the upcoming ICD-10 changes, especially as they relate to the practice of dermatology. And most of you who work in dermatology are already familiar with the Inga Elzy Practice Group. They are, of course, a private company, but one which focuses exclusively on dermatology billing, and they will no doubt do a good job of deciphering some of the trickier aspects of how ICD-10 will be applied to dermatology. And finally, the American Academy of Professional Coders and the American Health Information Management Association are also great resources, especially for professional coders. Just be aware that, while these last several resources are excellent, most of what they offer does come at a price. So with that said, if you or your office staff have found this introduction to ICD-10 helpful, why not learn more about us? You can visit our main website at dermatologytech.org. We offer a 15-hour online course written specifically for educating dermatology medical assistants and clinical support staff. Individuals can earn both certification and CEU. Even the billing staff can earn AAPC credit. If you otherwise have any questions or comments for us, you can also reach us by email at info@dermatologytech.org. Thank you.